I'm going to get started. I have no disclosures, so I just thought I'd say that.
Okay.
So, we started kind of basic things. So, today we'll just talk about, how do we currently manage, brain tumors or gliomas. There's been a more recent shift over the past few years in how we classify tumors. And I think that's important in how we kind of think about, management as well, and then some future ways we may be moving forward, and can we better take care of people with brain tumors. So, just kind of introduce, what is a glioma? Let's start off with that. And this is any tumor that arises from the supportive tissue in the brain or the glial tissue in the brain. So those are called glial cells. So glioma arises from that. So there's many kinds of gliomas, if you will. The vast majority of them, actually at least the ones that affect adults mainly, they widely infiltrate the brain tissue. So that's what unfortunately yields them as mainly incurable, at least surgically, because they don't have clear margins. They have infiltrating roots into the surrounding brain tissue. And because of that, even small tumors in the brain, they can have significant morbidity, or what that would mean, just a lot of symptoms that go along with it. And even small tumors, or even less aggressive tumors, can sometimes impair quality of life quite a bit. And what we see most commonly in our clinics, in our practices, are kind of higher grade brain tumors. Glioblastoma is the most common thing that we see. And these tumors, unfortunately, still have a generally poor prognosis despite our aggressive management and all the improvements we've made. So on the right, you see kind of a pie chart of the different kinds of general gliomas we see in adults. You see glioblastoma in red is the majority, over 50%. So it's kind of bulk. What we see, the rest are just single-digit percentages, kind of a smattering of them. And those include our lower grade brain tumors. These are also tumors that people do better. But what's important to keep in mind is that people with these lower grade brain tumors, they live longer. So it's important to keep that in mind in how we think about treatment, short term and long term, because that can really impact how people do overall, longitudinally as well. So these are very challenging tumors to treat. I know if you're on the call, you've had loved ones with gliomas. Unfortunately, this is all very real to you. Something we kind of have a significant challenge with, on a day-to-day basis. Part of the difficulties in managing tumors is the brain is not like any other organ system. It's not like the lung, it's not like the skin, where part of it cannot function and can generally be overall okay. And the brain has very eloquent areas, so that control physical function, cognitive function, psychological function, emotional function. So they're all things that the brain is heavily what the brain does, and little bits of injury can affect that. One of the other challenging biologically is, the brain is protected by a barrier. I'm sure you may have heard of this, something called the blood-brain barrier, that tends to stop some drugs from getting in, many drugs from getting in. But that's kind of an opportunity for us to try to learn and do better. We'll talk more about that later. How do we address this blood-brain barrier? Part of our challenges are also this limited understanding of the diseases themselves. Why are the tumors formed to begin with? How do they invade the surrounding brain? How do they evade the immune system and our treatments? Why do some treatments, why do some tumors develop resistance to, radiation and chemotherapy and targeted therapies and things like that? How do we classify people better? Like, how do we stratify, who is someone who's at high risk for certain complications or certain response to treatments versus people who we think we can maybe be less aggressive. Currently our treatments are pretty broad shotgun approach where, despite what you have, the treatments tend to all be fairly similar. And then also what's very important for me is not just how do we manage people, it's how do we take care of the impacts of the tumors themselves and the treatment related impacts on quality of life. That's an important aspect of managing tumors in people and families who have tumors, brain tumors. And so the management for this tumor is multidisciplinary. So it's not just me, it's not just a surgeon, it's not just a radiation oncologist, it's all of us. It's also our pathologists, so neuropathologists, radiologists. So these are people that you rarely, if ever, see in the forefront. These are our colleagues in the background who provide us with lots of very important information that guides us on how to best, manage people with gliomas. We also work closely with our colleagues in the palliative care, so kind of symptom management. Surgery, that's kind of standard. You try to remove as much as you can safely. People tend to do better. After that, people get radiation chemotherapy. Radiations can be quite effective, but there are risks of delayed neurotoxicities where people can develop, confusion. They can develop cognitive slowness. They can have weakness. They can have language issues, and basically slowness of thinking can develop with radiation. And chemotherapy as well can sometimes also be toxic to the nervous system as well, toxic to the body. The chemotherapies we tend to use often are pretty well tolerated. However, they all have their potential risks. These are not targeted therapies that we often use. As I mentioned, our pathology radiologists, these are our colleagues, our other physician colleagues who, look at the tumor tissue. They do a lot of advanced molecular studies that can help, and that's adding more and more information lately. And, people coming in for MRIs frequently, that helps tell us, in addition to kind of how you look and how you're doing, what's going on in the brain. Oops. So we'll talk a little bit about surgery. And the convention is what's called maximal safe resection. What that means is how can you remove as much as you can without causing any additional neurologic issues. That's really important, because if we cause more damage with surgery, then people just don't do as well. But a lot of times the surgeons can remove quite a bit and not cause any problems. And the more tumors removed, oftentimes the better people can do. Not always, but better people can do. And there's several benefits to surgery if it can be safely performed. It basically helps us establish a diagnosis. That's what we need to tell us what's going on. By that we mean what the tumor is, what the grade or how aggressive it is. Molecular studies are becoming more and more important as we're learning more about them, and we're developing drugs that can potentially target these abnormalities. Removing the tumor surgically straight up removes the mass effect that the tumor is causing on the brain. The skull is a fixed cavity. The skull will not expand or contract. Unfortunately, if there's a tumor in there, it can cause mass effect. So removing that bulk helps. But it helps by immediately removing the mass effect on the brain, and by removing tumor bulk, can also help delay tumor progression, the speed at which tumor can return. And so we know there's much data that is developed over the past several decades that show that people who develop more extensive surgeries or are able to have more extensive surgeries oftentimes do better in both the duration and quality, survival. And this is kind of a quick, again, these aren't things that I want you to focus numbers on or anything, just a general trend. So on the left column is complete, how people do complete surgery. Subtotal is when not all of it's removed, and biopsy is just when only a small sample can be removed. And you can see the difference in survival can be quite striking. From biopsy compared to complete removal of the tumor, they can be nearly a doubling of survival. So this is why our surgeons, we're trying to figure out better, more unique ways and more intensive ways to kind of remove brain tumors safely. That's kind of what we see in our aggressive brain tumors in glioblastoma. This has also been shown in patients with people with lower grade tumors. People who had some biopsy only versus people who had more tumor removed. You can see on this little table, again, I don't want you to focus on numbers or anything, but it's mainly focusing on general trends of lines. So this is what we call a survival curve. So the less steep a line is, kind of the longer people survive. So you can see this top line, people do better, and those are people who had surgeries done up front versus another group who primarily did biopsies. So you can see that that's why people with lower grade brain tumors, we tend to favor more aggressive surgeries up front rather than waiting, as they used to be convention in the past. So this is one update that's kind of happened over the past decade or so. Now we know how we classify tumors is very important. One big organization, again, this is always evolving, it's never static, but there are kind of major time points or major publications that in certain periods of time that kind of change the way everyone looks at brain tumors. So the big organization is the World Health Organization, the WHO. They recently updated in 2016, and the update prior to that was 2007, that's almost a decade. In that period of time, the way we classify tumors, how we define them, has changed from just merely looking at what to look under a microscope, which is kind of just kind of very, we still do that. It's replacing, it's in conjunction, where we look at tumors under the microscope, but our pathologists, in addition, this is our newest classification where we look at specific molecular features. So histology is how a tumor looks like under a microscope, and then we also do the additional molecular testing. And this more cleanly and provides us more data and helps us counsel patients on kind of what we think their tumor is and how it may behave and how it may respond to treatment. That's just all a bunch of charts. So I don't want you to focus on that. And this is kind of a nice, clean example about how on the left is how we used to classify tumors. On the right is the newer way. So basically, this is a bunch of lines. On the left, you can see these lines intersect, and it's kind of a mess, basically. On the right, you see there's 5 lines, and they more cleanly separate out. So this is what the addition of some of these molecular features, motion testing, kind of helps us prognosticate, predict, excuse me, is how people can do in a more accurate fashion. Again, this is not 100%. There's much more going on than just this, but these are things that we're actively working towards and trying to get better at. As I mentioned, what separates brain tumors, gliomas, it's very, very location dependent. You can have a tumor in one part of the brain that may ultimately not cause many symptoms. You can have that's maybe 10 times the size of a tumor that's in a smaller area, but it's in a more eloquent area, more of a critical area, and then it may cause more symptoms. And so what separates the brain from any other organ system is that it's very, very location dependent. The lung doesn't matter if it's in one lobe versus another. This is very different. This is kind of a way that we think about motor symptoms. Certain parts of the brain are more involved with the motor system. Some parts of the brain are more involved with the sensory system, excuse me. And then some certain parts of the brain are much more involved with the cognitive aspect. Again, this isn't to memorize this, but just to get a sense that location is very important when it comes to brain tumor management. It's what we take into account, and there's something surgical, something not surgical. What symptoms would we expect? What symptoms would be counseling on to look out for? What to tell us about? And this is why this is really important. So we'll talk first. Again, we're going to go and just kind of go a little bit, based on each tumor. We'll start with glioblastoma. It's the most common tumor that we see in our clinics. It's unfortunately the most common brain tumor that affects the general population, and unfortunately, it also tends to be the most aggressive primary brain tumor. It can affect people. The general age range is in the 40s to 70s. The median or kind of middle would be the early 60s. And unfortunately, survival is fairly poor in general. And our goal is to kind of improve this and optimize this and improve quality of life for the amount of time we're able to achieve. And, unfortunately, even with all the advancements we made, survival in many cases tends to be 1.5 years, 2 years. But we have more and more people who are living beyond that. And we'll go through some of that as well. This is just kind of quick set of pictures of what these tumors look like, and kind of basic, the actual tumor, the tumor itself. This is a slice of the brain. You can see that there's a tumor that infiltrates the entire brain right there. And so, as I mentioned, standard treatment for kind of most tumors is how much can we remove. We have the idea that it's to decrease the mass effect, how much brain pushing is going on, the swelling as well. And the less tumor that is present in the brain, you can imagine it's easier for what we do afterwards to be more effective. The less tumors present, the more effective, the more likely the radiation, the chemotherapy is to work. Imagine there's less tumor cells to kill, basically. And treatment is usually stepwise in different phases. Phase 1 would be surgery. Phase 2 is a combination radiation chemotherapy for about 4 to 6 weeks. Depends upon many things. How part of it's how fit a person is, how ill a person is, sometimes their age as well, on kind of which radiation or chemotherapy scheme that we consider. That's the second phase of treatment that goes for 4 to 6 weeks approximately. This is followed by additional treatment for about 6 months. Then we also use something called tumor treating fields, which is a novel, non-chemotherapy, non-surgical, non-radiation way to treat tumors. We'll talk a little bit about that later. This treatment regimen has shown to be beneficial in kind of some large studies. This is kind of an older study from about a decade ago, over a decade ago, wow, at this point. This is a study that showed kind of our gold standard of care now, where we realize that chemotherapy in addition to radiation is better than radiation alone. This is kind of a quick table. Again, this is not really to focus on numbers or anything, but you can take a look at these lines. You can see addition of chemotherapy to radiation clearly has a benefit in how people do overall. There's a population of people who specifically benefit from our treatments. And this is kind of the holy grail of medical management, not just in tumors and cancer care. It's anything. It's just what's called personalized care. How can we predict how someone will do based on certain molecular features of a tumor? And one of those things is called MGMT. You may have heard about this or read about this. This is an enzyme in the brain, and the tumors it repairs damage to DNA. What we're trying to do with our chemotherapy is actually damage that tumor DNA. So if you have something going after and fixing the damage we're causing, then the treatment, specifically chemotherapy, temozolomide chemotherapy, is less effective. But if you have a version, about 30–40% of people have this, where the specific enzyme is not as active, and it's not black and white. It's not a binary thing. It's a bit of a range. We have people who respond really well to chemotherapy because the damage we're causing to the tumor, not to the body, but to the tumor with chemotherapy, is not being fixed. So the tumor, we have certain people who really derive tons of benefit from treatment. So you can see in this little chart here, one line is considerably different than these other lines, and those are people who have this molecular feature. Again, it's not the only thing that matters. This is one of the most well identified, one of the best studied features that we look for, and it's an important part of how we guide therapy. As I mentioned earlier, so in addition to oral chemotherapy, we also use something called tumor treating fields, or Optune. This is basically, it is a new way to treat tumors. Currently, it's been most studied so far in brain tumors. It's being studied in other tumor types as well now. But basically, it is these arrays. You can see this person here is wearing, they have skin-colored arrays now on the scalp, and it delivers electrical frequencies that alternate and that stops tumors from dividing. This is a treatment that works better the longer you wear it. We have data to support that if you wear it for 90% of the time, like all the time basically, people do better when you compare to people who didn't wear it as long. So people who wore it longer tend to do better. So we really encourage people, if they're on this, to wear it as long as they can tolerate it. And it's pretty well tolerable. It doesn't tend to cause lots of symptoms. It's oftentimes this kind of skin issues is predominantly what we can see. And this is kind of just a quick schematic on how this treatment works. Again, not to look at the nitty gritty, but basically for any cell to divide, proper cells, including tumor cells, like normal cells versus tumor cells, they have to create the scaffolding for your genetic material to equally divide, go to opposite sides of your cells, and then split equally. If that doesn't happen because the scaffolding is incorrectly, it's not assembled appropriately, if there's uneven splitting of the chromosomes, this tends to lead to cell death, including tumor cell death. So this is why this treatment works in multiple ways to help promote that. And there was a nice large study. Again, in order to prove something that works, we have to do large studies for it. And this is another kind of table, again, not to look at the numbers or anything, but to kind of look that there's a group of people who did the tumor treating fields in addition to the standard therapy, which I talked about earlier, do better than not being on this treatment. It's one thing that we should probably talk a little bit about is how do we treat this aggressive brain tumor in people who are elderly. Unfortunately, being older, no matter what is a negative risk factor for this tumor. But we don't have a defined age. What is considered elderly? Some literature says 65, some say 70, some say 75. It's really not, a clear-cut number. There's much more that goes into that definition. And why this is important is because, as I mentioned, this tumor tends to be is the median age of the middle age. That means half are older, is in the mid to late 60s. So that means that and beyond are what we would consider elderly. So we need to figure out how do we treat our patients better, again, with the idea that we're trying to minimize toxicities from treatment while still not sacrificing the efficacy of treatment. And there's different ways in how we approach it. Some of it depends upon molecular features. If we think that you may not derive benefit from chemotherapy, then we may say, well, perhaps we should hold chemotherapy just do radiation alone. When it comes to radiation, do we do the traditional full 6 weeks, or do we do a shorter course that we think will still have benefit but not cause problems? So we must balance age, frailty, and kind of treatment-related issues. Again, another study that was really helpful for us that showed that people who received a shorter course radiation with chemotherapy, there was no major difference in how people did, but we do know chemotherapy and the short course radiation that people did better compared to radiation alone. So that's why we tend to favor the combination even in elderly patients. But what's important is that some of the molecular features that we saw really benefit people who are younger may not be as important. It is important, but it may be a little less defined in people who are older. There may not be as much of a survival advantage in people who have this molecular feature in elderly population. Again, it's not 100% clear cut. These tumors unfortunately do come back in many cases, if not all cases. And there's no clear standard of care in how to manage people. So this is actually very short. There's no standard of care. So this is where there's a lot of things that we can think about. We have studied many, many drugs in this setting. Most of them have not succeeded. There's many different options. So we use drugs like Avastin or bevacizumab. That's very standard. That's a commonly used agent. We consider someone as a good surgical candidate. Can we go and remove tumor again? That's a very attractive option, especially if we have something special to add on top of it. Like, can we offer people a novel therapy, a clinical trial potentially? There's other chemotherapies that we use in certain cases. We won't go into the depths of it. Sometimes we also offer repeat radiation if you're far enough from the initial radiation. So that's an option as well. Now we'll talk a little bit about our lower grade brain tumors. So these are the tumors that I think are they tend to be managed similarly, but these have a different biology to them. These also are infiltrative. They grow into the brain more slowly. These tumors do have a risk of becoming more aggressive down the line. And again, just as before, anything in the brain, symptoms depend upon location of the tumor, the size of the tumor. But oftentimes, we'll have people who have relatively minor symptoms despite sometimes large tumors. So maybe because these tumors can grow a bit more slowly, and so the brain has accommodated to a certain degree some of the changes. And these are tumors that tend to affect younger people more often, so 20s, 30s, 40s, and sometimes a little bit beyond. And these tumors often have specific mutations. This is where our mutational testing is so important, and where it has really changed the way we think about these tumors and how we classify them. There's two kind of major types of lower grade gliomas. One's called astrocytoma, the other is an oligodendroglioma, and some of these depend upon molecular features. We won't go into the depths of it, but one tumor type has something and the other does not. And that can help, that may help us with management. Who can we maybe defer, some radiation up front? Who can we maybe consider chemotherapy only? So we have to think about people's longevity into treatment decisions, because if we make a decision now, it has significant impacts 5, 10, 15 years down the line. So these are tumors that we have to be a bit more nuanced with how we approach. Not everyone is the same. So these are tumors that tend to grow slowly, especially before they become aggressive. And so, there's studies, and it makes sense. The slower a tumor grows, the less aggressive it is, the better people do. So tumors that grow more slowly, people tend to do better. And tumors that grow quicker, people don't do as well. And there's some study that showed, based on the amount of growth, that's a 4 millimeters a year, 4 to 8, 8 to 12, and beyond 12. That makes logical sense. A fast growing tumor is going to be associated with not doing as well. Not everyone with this kind of tumor behaves the same. There's several factors that we look at. Again, these aren't the only things that we look at. Some studies said age was important, although this is not as important as we think. If you're 41 or 42, does that really make you high risk? I tend not to feel that way. There's some studies where they looked at a larger sample of people where they didn't say age was really that major of a risk factor. It can be, though. And again, some of these other risk factors tend to make sense, and they all tend to be somewhat related. If you have neurologic symptoms, you tend not to do as well because if you're weaker, you have confusion, you have a lot of seizures. So that already sets you up for more neurologic issues. Low performance status, that means kind of not doing as well. So again, those will go hand in hand. Larger tumors, they're bigger, they're sometimes harder to remove completely surgically. So again, that fits into that. Tumors that go across the midline of the brain, that cross from one side to the other, and these are tumors that are hard to remove completely surgically. So again, that kind of fits. Larger tumors, can't remove them completely. And we do know astrocytomas compared to oligodendrogliomas, they tend to be a bit more aggressive. So we do consider people with lower grade astrocytomas, we may treat them more aggressively up front because we think they may be a bit more aggressive long term. And then I mentioned the mutation IDH, so people with this mutation tend to do better. However, we know that you can have a lower grade brain tumor, technically, like grade 2 under the microscope, but if you don't have that mutation in IDH, we nowadays, oftentimes, not all the time, but oftentimes will consider you to behave, the tumor will behave potentially as a more aggressive tumor, potentially even as a grade 4 tumor. So this is why this is really important in how we, when we test for these tumors, do they have this mutation or not, because it really can define how people may do, with treatment. So we call people who have these lower grade brain tumors, but without that mutation, molecular glioblastomas in certain cases, because although in the microscope they may not have the traditional features that we would see in an aggressive tumor like a glioblastoma, but we suspect biologically they may ultimately behave like that. So that's what they consider molecular glioblastomas. But there are more mutations that are being defined. So not everyone in that category behaves the same. So again, this lecture is probably not the venue to go through all of that, but that is a major thing that we look for. Let's talk a little bit about radiation. Radiation, again, is a critical part of treatment for these tumors. One thing that we have to be kind of careful about is when do you do radiation and how much radiation do you deliver? We tend to favor doing lower doses of radiation. Higher doses, we think, may not actually have a major difference in how people do, but are definitely associated with worse outcome, quality of life measures. We know for sure that higher doses are associated with that. So we tend not to do higher dose of radiation for people with these tumor types. When to do it or not, that's a bit of a controversy. You can kind of go either way. Some of it depends upon how much surgery you had, was all the tumor removed, how much is left behind. If there's tumor left behind after surgery, then we tend to favor more aggressive therapy immediately after. But potentially you could maybe even consider delaying radiation after surgery until you see some tumor growth. There may not be an actual impact on how people do overall, but it does make sense that if you have surgery with nothing immediately following it, tumor may grow back faster because nothing was done after. But it may not ultimately lead to a difference in overall how people do. So that's kind of a nuance that, us as a neuro-oncologist, we always discuss that with our patients, and we discuss it amongst ourselves, but when to do radiation, now or later. So like as I mentioned, we offer radiation to everyone who have tumors who cannot be completely removed, because we tend to believe those will probably come back sooner. Delayed neurocognition issues. This is a major problem that can develop after radiation. So this is why it's really important and which type to study. what's probably the best way to deliver radiation, the modalities and the dosing, to minimize effects on neurocognitive function and quality of life associated with it. Chemotherapy is also an important aspect of management for these gliomas. There's different regimens that are used. One is the one that we have a lot of good evidence for. We'll talk a little bit about that. Another regimen is we think is just as effective, but we don't have the final information yet because we don't have a head-to-head comparison between two of these regimens. We do know the single drug regimen, the temozolomide, which is what we use for more aggressive brain tumors. We know that it has a better toxicity profile. People tend to tolerate treatment better. In some centers, it may have replaced the multi-drug regimen, but the important thing is we don't know for sure if one is better than the other. Do we maybe shortchange overall how people do because one drug has a better toxicity profile and how tolerable it is? So that's another area of research, another area of study that was ongoing, and it is a discussion that we have with all of our patients and amongst ourselves as colleagues about what the appropriate chemotherapy regimen is. What's important to know for these tumors, because they tend to grow more slowly, it's actually very, very challenging to actually study these tumors and how people respond. This is an example, so I don't want you to again memorize any of those things, but what this trial is called RTOG, it's Radiation Therapy Oncology Group, 9802. So what I want you to know that 98 means that was the year the study was started. This paper, the results didn't mature until the mid-2010s, so like 2014, 2015, if I recall. I forget the year, but that's multiple decades of follow-up that had to occur for us to know that addition of chemotherapy was actually beneficial. In the past, that people would just get radiation alone, but we know that addition of chemotherapy to radiation is beneficial. And this is, again, not to know any of the numbers, but on this top left graph here, what's an important kind of line to kind of look at is these curves. You can see for the first few years, they're actually head-to-head. So again, if you didn't follow these people on study for over a decade, we wouldn't have known as much that one group will do better than the other by a decent margin, because that curve did not really separate out until years later, basically. So that's why what I mean by people with low-grade brain tumors, it's really, really hard to find out what's the best regimen, because we won't know for a long time what we did earlier. So that's a bit of a challenge that we're trying to figure out how best to address. How do we design clinical trials that are a bit different? How can we kind of find different methods to what's a different marker for outcome? Is it just how people do overall? Is it how fast tumors growing? Is it the way imaging looks? So there's a lot of different things that we're trying to figure out what's the best way to follow outcome, tumor outcome, and patient outcome, in these trials. So that's a little bit about kind of where we're at right now, and what advancements have been in the more recent few years. But I think the important thing is where do we go from here? Where are we going? Us and every group around the world is doing a lot of interesting and important work. Because despite all this aggressive treatment that we have done, outcomes are still not great. The advancements have been relatively slow. Right, every decade or so, there's been maybe an additional treatment. So we trying to do better. We're figuring out and we're learning a lot. There's a lot of science happening. We're trying to translate that from the bench, from the research labs into the clinic space. How do we bring some of these new drugs or new agents to patients sooner? We're increasing how we understand the tumor biology itself. How these tumors grow. Why do some grow quickly? Why do some tumors not grow very quickly? And even though they're technically the same tumor, what molecular features drives one versus another? Why do some tumors have resistance to treatment? How can we prognosticate and risk stratify with all this information that we're getting? And then again, also, how can we improve monitoring? There's a lot of measures that we can look at to see how people do. It's more than just how MRIs look, and it's more than just how long people survive. But there are other things that we should be looking at. And so just as earlier, it's multidisciplinary advancements. Surgery, our surgeons are continuously improving techniques, finding new ways, doing new preoperative testing, intraoperative testing to get a better sense of where the tumor is, what damage it's causing already, how can they remove as much of the tumor as possible, as much as they can without causing additional damage. And so our surgeons do certain MRIs. They look at the fibers in the brain. They're doing surgeries awake now. They're mapping the fibers in the brain. So they stimulate the brain and they know, okay, well, that's safe to remove, so they can go in and do more. MRIs can be done sometimes in the operating room to get a better sense of where the tumor is. Can they go and remove more? And also during surgery, we are now studying ways to deliver drug actively in the operating room. There are some old studies where they implanted these wafers, but there's things we can do better. Or can we deliver agents directly into the tumor bed that can treat tumors, but can it also synergize with radiation and chemotherapy down the line? So, surgery is an initial step that is actively being improved upon, and not just remove the tumor, but deliver things that we normally couldn't do. Radiation, that's another field that there's a lot of advancements being made. Different type of technologies that have developed over the past few decades. They're continuing to improve them. So how can we deliver radiation more precisely, treating the tumor itself while sparing normal brain tissue? How do they figure out what the right dosing is? Can they do focused radiation versus more broad radiation? So those are also advancements that are being made. And then chemotherapy. So this is where there's a lot of room for active improvement. Is precision medicine. Can we target molecular features in drugs with targeted therapies? How do we get drugs to penetrate the blood-brain barrier better? Do we design drugs to be smaller and more likely to get in? Do we actually disrupt the blood-brain barrier by using ultrasound? Do we use drugs to open up the blood-brain barrier? Immunotherapy is all the rage now, and not just brain tumors, but in any tumor type. How can we use our own immune system to fight tumors? How can we modify genes in tumors to help manage them? So a lot of room for improvement. A lot of studies being done in all of these different aspects. In addition, our pathologists are actively studying. I mean, we have updates. They meet frequently, and how do we better classify tumors? Again, to stratify people based on certain risks. Can we look at other aspects of tumors? If you take a tumor out surgically, it's not all the same. Some of the tumor we know is going to be more responsive to treatment versus others. How can we identify that? And how can we identify what makes it that way? Can we change that? Our radiologists, this is what we routinely use to follow tumors. Right now, we have some limited sequences, some limited technologies, but there's ways to better look at a tumor response. Oftentimes we get MRIs and we don't know if the changes are because of there's tumor growth, or is it some sort of changes from our treatments. Our treatments cause changes on the MRI. There's inflammation, there's surgical changes, radiation changes, chemotherapy changes. So how do we use advanced machine learning to help maybe differentiate things that our eyes can't really interpret? Do we use biomarkers imaging-wise to see if a tumor is really aggressive? Can we see a specific biomarker? If it's getting less aggressive, does that mean it's responding to treatment? So there's a lot of work being done there. So as I mentioned, neuropathology a little bit. So this group C impact analysis is a group that a lot of world-renowned neuropathologists are part of. And this is to kind of know any of this, but specifically, these are active changes that are being integrated into our neuropathologist workflow every day. And we're adding more information. This gives us more information for our patients to say, okay, well, your tumor is this, but it has this, so we think you're going to do this. So this really helps with prognostication in certain ways. Pathology is also helpful, and we know certain people with certain tumors may more likely have seizures versus other tumors based on certain mutations. So does this information, will this translate potentially into other therapeutics? If we know people with a tumor with certain mutation may have more seizures, Will treating the tumor help seizure control? Will seizure control help the tumor? So there's a lot of different things that are important. We know that there's an increasing relationship between the normal brain function and the underlying brain tissue. There's a lot of communication happening. This is just a little bit about also the importance of machine learning. What I mean by that is our our pathologists work with AI and how to better identify certain areas of the tumor. If we can say, well, one part of the tumor has certain mutations, whilst other parts of the tumor have different mutations, will that help kind of let surgeons know, will this tumor let us know? Because more of a tumor has this more aggressive mutation versus others, we think the disease may not respond as well. And so these are things that our human eyes has a significant difficulty with distinguishing. How can we differentiate tumor from brain swelling? How can we differentiate tumor from radiation effect? These are all things that can be sometimes hard for the human eye to see, but this is something that potentially computers may be better at, and to help us with, not replace it, but help us. Same thing can apply to imaging. Traditional MRIs, they're great, but we know that they're limited to a certain degree. They only tell us kind of anatomically what's happening. We know that there's more to the tumor than what we see on the MRI, so we have to know that to plan for treatment. And so it's often difficult to interpret these basic MRIs that we do, these routine MRIs, traditional MRIs that we do. And so we're doing more and more advanced things, like looking at blood flow to the brain to help us differentiate between tumors versus treatment effect. On the right is a picture, which is kind of a nice, clean example. It's never this clean. I wish it was always this clean, but you can see this first picture here. You see a lot of red and yellow that we think that means a lot of blood flow going to the tumor. As you move on, there's less and less of it, so that's consistent with the tumor responding to treatment. Do we do something called PET scans, which helps look at energy usage in certain parts of the tissue, any part of the body? Can we use it specifically in brain to see if something's using more energy? Does that mean it's an active tumor growth versus less, which is less tumor growth or more treatment change, basically? Again, imaging, machine learning, and radiomics is kind of the science term, if you will. Is trying. They're working on ways to extract all this information we're capturing when someone's in an MRI machine. An MRI, you're there for like 30, 45 minutes to maybe an hour sometimes. We're capturing a lot of data, a lot of information. Can we use that information that we've already captured and find more and get more information? Can we use machine learning to help differentiate that potentially? And can we use that in conjunction with pathology to maybe help differentiate some of these things? Talk a little bit about what's called the precision medicine. That's the holy grail of medicine in general, not just cancer care, but especially that's where people really talk about it. But really, it's been looking at in every medical situation. And this is where the molecular information, genetic information of tumors is really helpful. Are there other ways that we can track tumor cells? Can we collect body fluid? Can we check your bloodstream? Can we pick up things in there that tells us what's going on in your brain? Can we check your spinal fluid? Does that tell us what's going on in your brain? Does that help give us more precise information to help us respond to treatment a little bit better? This advancing technologies is also making things cheaper overall. Now you can do full sequencing of a tumor. 10, 15 years ago, that was very cost prohibitive. It's still expensive, but it's something we can more routinely do. We can order it easily, and we get a report back in a couple of weeks. Something that we couldn't do some time ago. A lot of hospitals are now doing in-house testing. So we have panels in our hospital. A lot of large hospitals have their own genetic testing panels that are done for specific tumor types. There's companies around the world that also can do testing. So there's an example of them right there. And then what does information help us with? Does this give us information that we can actually target tumor cells with specific drugs? That's the ultimate goal, basically. I mentioned this blood-brain barrier. It's quite pesky. It stops a lot of drugs from getting in. A lot of traditional chemotherapies that we've used for other tumor types, breast cancer, lung cancer, colon cancer just tend not to get into the brain very well. Some do, some don't. So getting, and a lot of the brain tumors, they infiltrate the brain. So the drugs may get into maybe the core of the tumor, where the contrast, where the dye gets into the brain tumor, but it may not get into the surrounding infiltrative bits. It may not get into the parts that are invading the surrounding brain tissue, because that part may be behind that barrier. So that limits a lot of drugs from getting in. And so getting that open may help drugs from getting in. Drugs that may traditionally we have thought to not be effective may work actually, or may be beneficial. We're just able to get them into the brain tissue basically. And so there's a lot of work being done, including at Northwestern, where they're finding ways to disrupt the blood-brain barrier. There's different ways to do that. One way that we're working on here is to use like a focused ultrasound. And the different ways that this is being studied. Here, the study is to basically implant these arrays of ultrasound on the inner part of a skull flap, if you will, that's placed after surgery. And then with that, you can just turn it on and disrupt the blood-brain barrier, then you deliver a drug. Then we look at that in an MRI, and we can see how people do. Can you deliver drug directly through the blood vessels? Can you skip the veins and go straight to the arteries? Does that get drug better to the brain with more perfusion into the brain tissue? Does using methods to kind of help the drug diffuse kind of in a nice even manner, just like water soaking through a cloth or something? Can you let the drug kind of seep through into the surrounding brain? Can you use drugs specifically that are designed to open up the brain? The blood-brain barrier is an important structure. It cannot be open forever. I mean, there's a reason it exists. It keeps the brain and the bloodstream in a very tightly regulated system. Inflammation can occur if the blood-brain barrier is open. So it's something that we need to be very mindful of. It's something that probably can't be open, for long periods of time, just for short windows to deliver some sort of therapy. So finding ways that we can more easily control that is an important part of blood-brain barrier disruption. Oops. Immunotherapy. This is, I think, one of the biggest changes that has occurred in cancer care over the past, decade or so. Specifically, a good example would be melanoma and lung cancer. These are tumors, cancer types that, before were death sentences. Now, people with melanoma, metastatic melanoma, can do quite well with immunotherapy. So we're trying to see, does that work for brain as well? Thus far, the results have not been great, but doesn't mean it won't work. It's just trying to find the right drug, right combination. It's really just immunotherapy by itself. You have to use, triggers to get the immune system active. You have to train the immune system to target the tumor, in addition to just revving it up, basically. And there's different approaches to immunotherapy. It's not just one thing. So that's why I think the combination is what's going to be really important in the future. We're studying that. A lot of people around the world are studying that. One ways that we do it is something about checkpoint inhibitors. So these are drugs that are on the market right now. You probably see commercials for it on TV. One drug you see on TV, something like Keytruda or Opdivo. These are drugs that are FDA approved for lung cancer, melanoma, kidney cancer, Hodgkin's lymphoma, a lot of things. And every day we're seeing more and more approvals for this class of drug. And these are drugs that basically help our immune system attack tumor cells that have evaded our own immune system. For some reason, these tumors and brain tumors are telling our immune system to stand down by down-regulating certain checkpoints. So these drugs inhibit those specific checkpoints. So it gets the immune system more active. There have been studies with using these drugs by themselves. Thus far, there has not been dramatic improvements in how people do. So combining it with other methods, I think, is what's really going to be important. One way that we can do that is we use vaccines. So a vaccine is a way for you to train your immune system to fight something. You get the flu vaccine, you get the pneumonia vaccine every year. So that's specifically, if you get either of those, the vaccine is vaccinated the body, your immune system is primed and ready to go. Tumors are a bit trickier, where you need to have an appropriate target. There's been many ways to try to create vaccines A lot of them are actively in study right now, so we don't have tons of final information for you. That'll take many years to come out. Some viruses, some vaccines specifically you take your own tumor cells, grind them up, and make them into small bits, and then you can inject them back in. That's a crude way to describe it, and get your immune system to specifically look out for that. Do you use vaccines that are targeted towards specific targets that we think are generic amongst brain tumors? Do we use vaccines that target a specific target, basically? And so it's personalized versus kind of more generic kind of targets. So there's a lot of work being done on different vaccines, basically. Viruses, you may read about this, some of the news frequently, people injecting viruses into tumors, and people are doing really well in certain cases. Basically the idea is, we know viruses are very, very small. They're basically small protein capsules that carry genetic information. Oftentimes they carry, cold viruses, coronavirus, whatnot. But can we engineer them to carry information that can be directly anti-tumor? Can they carry information that can cause tumor cell death, that can stimulate an immune response, that can deliver some sort of gene therapy? So a lot of places are using different viruses. Do you use a cold virus? Do you use poliovirus? Do you use herpes? Do you use Zika? Do you use the measles virus? There's a lot of different viruses being studied. But they're basically, the general principle is that these are small, I don't want to call it an organism, it's not technically an organism. The small things that can kind of carry genetic information. And because that they are in all of our bodies, can they traffic towards the nervous system? Do they have a predilection towards the nervous system? And thus they may evade the negative aspects of our immune system. Because if you have a cold, you want your immune system to attack it. But if you have this cold virus that's engineered, you don't want your immune system to deactivate what we're putting into the body. So there's a lot of work being done on this. This is another kind of engineered immunotherapy, basically, where people are studying, can you take your own T cells, which are this this kind of toxic cell to infections, to tumors even. Can you take one out? Can you engineer them to a specific receptor on a tumor cell, and that promotes the immune system to target that tumor cell? These have been shown to be a bit more effective, or more effective in leukemias and lymphomas. That's where a lot of the active benefits are being seen. There's risks to them. We won't talk about that right now, but they're being studied in many tumor types, and they're being studied now in brain tumors as well. How can we use this engineered, our own immune cells that are designed to attack? How can we engineer them to specifically attack our tumor cells? Those are called chimeric antigen receptor T cells, or CAR T cells. It's probably something you may have seen on the news, or 60 Minutes or something. Gene therapy, this is kind of this old concept. It's kind of maybe one of those early things that, can you just change the genes of a specific thing? Can you change your genes to, lose weight? Can you change your genes to help cure diabetes or, insulin resistance? Can you use gene therapy to treat genetic disorders that people are born with? So it's a very kind of logical way to think, to maybe approach brain tumors as well. Gliomas, but think of the general principles. You have to have a vehicle. Oftentimes these can be the viral vectors we talked about earlier. You can use some of the modified viruses. You can use stem cells. Stem cells can also be nice vehicles to get this genetic payload delivered to the body, and it has to traffic to the tumor cell, basically. Can you use just straight up engineered particles, nanoparticles? Can you use particles made of, genetic material? Can you use particles made of metals? Can you use particles made of fats or lipids, basically? So there's a lot of different particles that are being studied. And there's different types of gene therapy, and they're not the same. Some try to stimulate the immune system. Some try to actually kill the tumor cells, but they're called suicide genes. You inject them into the tumor cells, and it causes them to die. Do you use gene therapy to suppress tumor cells? Do you basically say, okay, well, I want to turn off this abnormal mechanism in the cells that's causing the tumor to grow. Do we just give you a gene therapy that stops that specific target? Do you do gene therapy that stops blood vessels from forming, because tumors require blood vessels to deliver blood and oxygen to it? So there's a lot of different ways to think about gene therapy. So it's not just a single, it's a concept, but there's many ways to approach it basically. And a lot of people are doing a lot of different ways. There's a lot of interesting work. And one thing that I think that also should be brought into the forefront in how we manage people with brain tumors is, we're focusing, of course, improving survival, improving how people do overall. Improving longevity is really, really important. It's probably one of the most important things. But at the same time, we want to make sure that we are not, we are not sacrificing quality of life and symptoms as part of as part of our therapy. The brain is such a unique organ. It is so sensitive to what we can do to it, with our own treatments. And it's important to kind of monitor quality of life. It shouldn't be just kind of a thing we do on the side. It should, I think, be a metric on how people do. Do our treatments help you live longer? Great. Do our treatments also help improve your day-to-day activity? Hopefully, yes. If they don't, then is that therapy really as important if it doesn't help improve your day-to-day quality of life? Certain things that are really affect a lot of people with brain tumors, really cancer in general. Fatigue is a major problem with a lot of patients. We don't have great therapies for it. A lot of it's because fatigue is very generic. It's a very broad term. People experience it differently. Many different things can cause it. Oftentimes, there's multiple things causing it. It's not just one thing. It's not just radiation. It's not just chemotherapy. It's all of it together. And so, different studies are being done around here and around the country, around the world, how to kind of improve quality of life, how to better monitor it as well. How do we, what are the parameters? What do we actually measure? It's hard to measure everything. We can't keep you for an hour trying to ask you all these questions and how to have you fill out surveys and have you do all these drawing lines and drawing clocks. That's not fair to your time as well. So you got to pick and choose what are good markers for overall cognitive function and overall quality of life. Working memory, kind of the memory you use to do day-to-day things. How to remember to complete a task. Where you put your keys, how to sequence. How to cook something, and these are all things that are part of working memory. In addition to long-term memory, attention span, all part of it as well. You say something, it's in one ear out the other. This can often be affected in patients with brain tumors. Attention just kind of goes away completely. Executive function, how do you sequence tasks and things like that? That's really important. The emotional well-being of patients and families is an important negative contributor to general quality of life. So again, that's something that is now a lot more people are focusing on that now than they were in the past, because we know that's such an important part of this management of cancer in general. How do we use that information to identify better medications, better supportive medications? Do we use drugs for depression? Do we use drugs for mood? Do we use drugs for anxiety? Do we use drugs for energy or attention? Can we use rehabilitation, cognitive therapy, physical therapy, speech therapy, or a combination of all of these things? So, I think and nowadays, most clinical trials, if not all of them, are integrating quality of life metrics and monitoring as a part of the study, because I think we're understanding how important that is as part of an endpoint. If someone told you we could give you something that would make you live, twice as long, but you couldn't do anything or you'd be miserable, then is that the therapy you want? Because the goal of all of our management is to improve and preserve quality of life at the end of the day. So that's kind of what we want to do. I think that's it. So thank you for your time and thank you for having me. It's been an honor and a pleasure to speak with all of you. If you have any questions at any point, please ask them now, or if something comes up later, feel free to email me. I'll just leave that right here on the screen, if you'd like. So, and I've said a lot. It's a lot to take in a short hour. So please feel free to ask questions if you have any.
Jotting down your email address first.
Okay.
Thank you so much for your time and effort and work and everything you put into this. This was very thorough, I thought. And a lot of it is familiar to me or a family member. And I'm just so glad there's progress being made. Certainly there are things more advanced here than I knew about 2 years ago. And I'm wondering, just as a common pedestrian out there, is there anything that we can do to either help people be aware of brain tumors or to be more getting more treatment or considering more things, or I don't know, or even in ourselves what to look out for, or is there anything we can do?
Yeah, no, I mean, I think, as caregivers, I mean, of course, there's a lot you can do there, but, as general kind of population, I think is increasing the visibility, there's more and more visibility kind of in general for brain tumor management.
Mm-hmm.
It's a very rare tumor. That's important. And what we see are quite rare.
Yeah.
So I think kind of increasing visibility, I think if people know that there's a network of support out there, I think that can help. I think just being a resource for, people who are going through something like this. I think sometimes it's all patients need. We have things from a medical perspective, like we can kind of go through all that, but we haven't lived it. And so I think sometimes all people need is just to know that there's someone out there who they can kind of communicate with, who they can kind of talk to, who they know that, they're going through the same thing. And I think that's where I think people like you can be really, really helpful and really, really impactful, is to be there as resources. I think it's going to be quite difficult. I mean, I doubt you want to relive kind of this, anytime someone calls. So, but I think those are things that can be quite helpful in kind of helping raise awareness, and also to be there for people who can, who are going through the same thing, just to know what to look out for, just those extra tips maybe. And a lot of patients who do that, they find benefit there.
And what should we look out for?
What do you mean? Like looking out for brain tumor symptoms? Is that what you mean?
I guess. I don't know.
Yeah, no, what's curious is, everyone, I always hear, oh, I have a headache, I think I have a brain tumor. It's actually quite the opposite. The risk of brain tumor and stuff with the headache is single digits, even less than 1%. I mean, of course, the symptoms to kind of watch out for that would help, help us, because the sooner you find things, the better people can do, I think. Any sort of neurologic issue, cognitive changes that are, someone's doing really well, but all of a sudden you notice that, they're having speech difficulty, they have difficulty kind of coming out with words, they have difficulty with memory changes, they're having, weakness, seizures, obviously, for an adult person. If someone who hasn't had headaches ever, all of a sudden they're like, yeah, I'm having a headache and it's getting worse over the past few weeks and months. Those are kind of red flags or yellow flags for us as physicians, that, okay, well, perhaps this is not just something basic. It's someone that we would maybe want to consider, getting a brain image. And we can do basic things. The head CTs, they're very fast, very quick. 5 minutes, you can rule out a lot of major things. So those are kind of those are things that you guys can look out for. People ask you, well, those are symptoms.
That's good. Thank you. And that there's possibly a quick check to just put everyone's mind at ease or get treatment.
But it comes out the other way. We always don't. It's important that we know not everyone needs a head CT just because they have a single headache. It's a constellation of things. It comes down to clinical judgment. But I know what you mean.
Yeah. Okay.
I have a question. Are there any changes in the MRI technology? I mean, I have MRIs constantly, and I don't know, it seems like the same songs for 20, 25 years.
Well, absolutely. A lot of them aren't visible to you. A lot of them are not something that you actively see. A lot of it's in the background. A lot of it is our techniques and sequences that our neuroradiologists are adding. I would say over the past year and a half or two, our neuroradiologists are exploring new ways to look at blood flow to the brain. What that means is to see, to help differentiate between what we think may be tumor versus treatment changes. There's new advancements in We look at spectroscopy, looking at certain molecular makeup of the brain. We're trying to do PET scans of the brain. Some of that's dependent on getting certain radio tracers, which require like radiation and whatnot. So there's a lot of nuances there. But yeah, there's a lot of advancements being done in imaging and MRIs. There's newer machines, higher magnet machines, which may give more detail. But a lot of it's in the background. There's work being done active, like in the research phase, but also like day-to-day clinically. Like there are more things now than there were a year and a half and 2 years ago.
It seems that Northwestern has more MRI machines than I ever realized, because
There's a lot of them.
I'm in new tubes all the time, but
yeah,
they all
there's new
seem
buildings
kind of
popping
the
up, and
same.
there's new MRIs in each of them. Some are not as loud, some are more comfortable. Yeah.
Right. So is that the new cool tool for more than just brain, but is it a more common diagnostic tool, or is it gotten more cost effective?
Yeah, I think MRIs are still very expensive studies, not just cost-wise, but, time-wise. Currently, there's studies where people had like rapid MRIs. The thing is, the data we need for certain things, like for example, like for stroke MRIs, those can be quite quick actually, because we're only for certain things. For tumors, we're looking at a lot of different parameters, and those require time. Like we have to do part of it without the contrast, and some of it with the dye that's given. Some of the dye is given earlier, then it's checked later. So that just adds on time in the machine. So, currently there's no major kind of changes in kind of like minimizing the amount of time in the MRI, but the increasing detail is really important in the newer machines that are present here and elsewhere.
Awesome. It's nice to know that my time is well spent.
Yes, it gives us a lot of good information. Yeah, those MRIs are useful. It tells us a lot.
Yeah.
All right. Well, again, thank you for being here. It was a pleasure to kind of do this, and I'm happy to do this again.
Thank you.
Hopefully in a real room one day.
Yeah.